now request Dr. Rwituja. She's one of the very young and very dynamic consultant on Vision Eye Center. Just request. She will talk a very relevant for all of us that topic, that relevant anatomy. The very, very important for all to decide, for all surgeries, all decision. This is very, very crucial. And that
I thank Dr. Jayanta for including me in this session, and it's something very interesting for us, lacrimal anatomy. And it's good that I'm going after Dr. Shalu, after a clinical talk, bit of break with anatomy, which includes the embryology and the histology, and a bit about the physiology of the lacrimal system. So the lacrimal apparatus is a very complex structure, and it about 4 months of intrauterine life, the canalization of the cord starts. So between the maxillary prominence and the lateral nasal prominence, you can see the nasolacrimal groove there. So this is basically a depiction of the lacrimal lamina stage, which I just showed, and the lacrimal cord stage by 19 and 22 weeks and 23 weeks. So the excretory lacrimal system maturation occurs towards the end, and problems in these are what relate to congenital nasolacrimal obstruction. So a couple of congenital anomalies which can happen because of abnormal embryological development is supernumerary puncta. So this can be because of multiple epithelial buds developing from the ends of the lacrimal cords, which I just showed. And dacryocele is another one, which is a fluid-filled area near the sac. So it's basically because of non-canalization of the lower end of the nasolacrimal duct. So I'll be coming to what the valve of Rosenmuller is as well. And congenital lacrimal fistulae they are accessory ducts. So they connect the lacrimal drainage system to the skin, and this is a pretty large congenital lacrimal fistula which I happened to see, and I showed it to Dr. Grover, and he said this is one of the largest I've seen. So it was a daunting task to actually operate on this. But there is a proper protocol that you can follow based on whether there is any lacrimal obstruction, nasolacrimal duct obstruction or not. And these can sometimes be very clean, like in this patient, or they can be associated with redness, swelling or discharge. And they can be unilateral or bilateral. So I'm sure this will be covered in the upcoming talks. So what we need to talk about is starting from the puncta to the canaliculi, the nasolacrimal duct, and the bit of nasal anatomy. So before that, we should talk about the secretory system of the lacrimal system. That is the gland, which has an orbital lobe, and the palpebral lobe, which is divided by the lateral horn of the levator, and it's located in the frontal bone, the lacrimal fossa of the frontal bone. So these canaliculi, there are sort of microtubules which come out from the lacrimal gland, and they give rise to the lacrimal secretion. So this forms a pool at the lower conjunctival fornix in the medial angle, which is the lacrimal lake. The punctal opening, it widens into the ampulla, so from the papilla to the ampulla, which is 2 mm in height, and it is perpendicular to the eyelid margin before taking a turn into the canaliculus. So this lacrimal papilla is what the punctum lies upon. It's a little raised structure, and no meibomian glands exist medially to the lacrimal papilla. So this is a nice, really nice electron microscopy picture, which Dr. Javed Ali from LVPI has been studying. So this is a picture of the punctum, and what happens is that the ones which are smooth, the area which is smooth is the part which is proximal to the punctal junction, and after that there are fine rugae and mucosal folds. So this is something which is being studied even now. The canaliculi are encased within the pretarsal orbicularis, and the sac is sort of surrounded by the lacrimal fascia. Now this muscle of Riolan is another part of the orbicularis per se. which surrounds the punctum and helps in the lacrimal pump, which I'll be coming to. So this is a drawing I made just to sort of depict the basic parts of the lacrimal system, and there are certain variations in this which we should talk about. The lacrimal pump is something which is not really fully elucidated, but it has to do with the contractions of the pretarsal orbicularis. But this lacrimal pump mechanism is something which is continuously in limbo. So it's not something which everybody agrees on, but the classical teaching is that when you blink, the puncta are occluded, and then when you open the eye, the canaliculi are emptied and the fluid enters the duct. So this is another pictorial representation of the same thing. And you can see how the common canalicus sort of contracts and expands to suck in the water by the capillary mechanism. Now there's something else called the Krebel flow, which has been studied, which has nothing to do really with contraction of the muscles, but it is mainly the flow of the lacrimal lake fluid without any blinking. So this was studied with PMMA particles which was suspended in a fluorescein solution, and this is new and upcoming ways to explain the flow of fluid in the lacrimal duct. Now there are considerable studies, dacrocystography studies, which have been trying to elucidate the actual anatomy of the system after the puncta. So the common canaliculus is present in about 94% of people. The common canaliculus is, however, absent in about 4%, wherein the upper and lower canaliculus directly join together at the lacrimal sac, nasolacrimal sac, and the upper and lower canaliculi can enter the sac separately as well in about 2% of individuals. So this is important to know that there are variations in the normal anatomy. Another thing is that people have said that the anterior and posterior limbs of the medial canthal tendon is what is sort of encasing the sac. However, people have now refuted this claim that the posterior limb could be the Horner's muscle, and it's a separate structure, so that the posterior limb of the medial canthal tendon that has not much to do with it. This is another thing which we should be aware of, is the mucosa-associated lymphoid tissue. So this is something which helps in the immune response of the nasolacrimal system, and as well as the various valves which are present all along the system. So the valve of Rosenmuller is what we commonly discuss, which is between the common canaliculus and the sac, and of course the valve of Hassner. Now, causes of nasolacrimal obstruction, definitely a block at the valve of Hassner could be because of a stenosis from a narrowed NLD or a hypertrophied inferior turbinate or bony abnormality. So these are anatomical causes for nasolacrimal duct obstruction. And the nasolacrimal duct sort of travels inferolaterally and posteriorly. So this direction is important to know when you're planning a probing. And the long axis forms about 15 to 25 degrees posterior to the frontal plane. Now this is just a depiction of few variations which can happen in the nasolacrimal, in the nasal anatomy, which I'm sure the subsequent instructors will be talking about on their course on endoscopic endonasal DCR. But the main thing that we need to know is the maxillary line and the junction with the middle turbinate. So you can see that this is the main area where the L-shaped incision is made for endonasal DCR. And this is a depiction of the anatomy of the middle turbinate. And above that you can see the maxillary line right there, right here where the incision has to be made. And anteriorly is the inferior turbinate, which sometimes has to be infractured in a congenital nasolacrimal duct obstruction. So that is a depiction of the surgery. So I'm sure the rest of the people will discuss on how to solve the problem of tearing. So thank you for your patience.